Welcome to Encounter, where we celebrate putting faith into action and community leaders who live out compassion, grace, and love. We're a program of the Broome County Council of Churches that addresses food insecurity through chow and the Greater Good Grocery, provides hospital and jail ministry, builds wheelchair ramps, and assists neighbors with transportation and shopping services through Faith in Action volunteers. We invite you to the conversation. Encounter your neighbors as we learn to walk together in love and kindness.
Good morning and welcome to Encounter. I'm your host today, Joe Sellepack, the Executive Director at the Broome County Council of Churches. The Council of Churches turns 85 years old this year. It's impressive. A length of time for any Council of Churches to have been open. A lot of councils of churches around the country have all closed, but we're still alive and vibrant and doing ministry. One of our first programs that came on board in 85 years ago was hospital ministry. Hospital ministry has been one of our first and one of our best programs that we've operated in Broome County since we started. To help us talk a little bit about the milestones, some of the things that are coming up, is our hospital ministry chaplain, John Snider. John, welcome to Encounter.
Thank you, Dr. Joe.
So, John, how are things at the hospital? I mean, it's been a while since you've been on Encounter. So, how are you fitting in? How are you finding the work there?
I really enjoy being at the hospital. I started as a volunteer in 2014 and volunteered for a lot of years. And then an opportunity was presented for me to come on part-time, and then slowly worked into the role that I'm serving now as a director of hospital ministries. And we've seen phenomenal growth in the number of patients, we've seen Wilson
UHS,
expand. Yeah, UHS is really expanding, but in response to that, we've kind of really ramped up kind of our engagement and our volunteers. I think we've probably well over quadrupled the services that we're providing now at the hospital. So it's been a really exciting time. It's been enjoyable, at times taxing, as you know, chaplaincy is.
Yeah, it can be really hard.
Yeah, for sure, it can be. But I wouldn't be doing anything else. I really enjoy what I'm doing at the hospital. So
as far as like what you're currently doing at the hospital, you mentioned some of the programs. What are some of those?
So we actually provide 24-hour a day, 7-day a week on-call coverage for the hospitals. So we have various chaplains, staff chaplains who provide that type of coverage. We also, any ecumenical services throughout the year across all faith traditions. We meet every faith tradition. In fact, like today I'm going to smudge a Native American this afternoon at the hospital. I know I'm going to do that. So we meet every faith tradition, whatever their faith needs are. So that's a big part of what we do, is kind of just providing a ministry of presence to people, regardless of their faith.
And so if a person goes to UHS, because UHS is one of the largest hospitals in our area. So when they go there, how would they get connected to your ministry?
Really, literally, all they have to do is ask their nurse to see a chaplain, and generally what would happen is a spiritual care consult would go in, and we would see that consult when we got there, and we would come visit them. And they'd see a staff chaplain. If they they can request, and we get a phone call sometimes too.
All right.
Yeah.
So when you think, what are some of the things that are coming up this summer that you're kind of working on currently?
Well, we're going to do some more recruitment. Currently, we have 15 volunteer chaplains. And we need to increase that number with the number of patients and staff that we see. We're probably running 12,000 patient interactions a year right now, and I bet you another 6,000 staff interactions. So we need to increase the number of volunteers.
So that's 18,000 over 18,000 interactions.
A year.
Yeah, let's let that sink in.
Yeah.
18,000 interactions. Now, what would an interaction look like?
So it just depends, because if you walk into a room, just simple introduction, and just meet a person where they're at. They could be grieving, they could be in pain, they could need grounding, just to, de-stress. So every interaction's kind of a little different. Some are very short, and then some can be very long. And we meet people across the spectrum. I can walk out of the ICU and then be in the emergency room, and then be called to labor and delivery, and then be dealing with someone who's struggling with their mental health, and then be in the next floor, be dealing with someone who's in addiction recovery. So it's a vast amount of different types of patients dealing with many different things. And so every interaction is just a little different. See end of life. We see a fair share of end of life interactions, and help patients and families walk through that as well.
It must be really hard to go from an end of life situation to a birth.
Yeah, I got called in a couple weeks ago on a Friday night, and literally back to back, that was the scenario. I did an end of life with a family in ICU, and then while I was in the hospital, a nurse grabbed me and said, "Hey, they really like to see a chaplain up there. They just have a new baby boy." And so like you go from one extreme to the other, you know what I mean? Like it was just a real, kind of could be a real downer and then a real upper, you know?
Yeah, it can feel like a yo-yo at times, right?
For sure.
Especially because some of those end of life situations are really tough.
Very complex.
Yeah, I remember I was sitting in for a pastoral call. I was sitting with one of my members of my church, and they kept coding. Someone else in the area kept coding, and everybody would go to it, and like all of life kind of shut down, and then they'd go back and forth, and it was a really traumatic experience for my parishioner, just to witness what was going on in the ICU, even though it didn't truly affect her.
Yeah. No, and there is a lot of trauma, and that's a lot of what we see with people. Some people are kind of misinformed. They think trauma is, I was in some big horrific event, but so many people are carrying trauma, and really trauma is something where I had an event, and now it's affecting me all of this time later, and sometimes you can carry it for a lifetime. And what we find is over 50% of all of our frontline workers carry trauma. And also moral injury, a high amount of moral injury. This injury where they just experience something that just doesn't line up with their worldview, or just doesn't go the way they would want it to go or should go. It's just not right, and it just really is something they carry. So we help a lot of people handle those types of trauma. We do a lot of trauma-informed care, a lot of moral injury care. And it's just amazing, 90%, almost as much as 90% of people who are in addiction or dealing with mental health, also usually its roots are found in trauma. And so it's a lot of the work we do.
Moral injury is an interesting word.
Yeah.
So unpack the actual category a little bit more than that.
Yeah.
Like what, so I experienced something that's outside of my ability to explain theologically. Is that kind of what
that could be that, or it can even, like, guess what? It just doesn't line up with the way that you perceive the world should go. There is so many times we have experiences where we just see that, man, it just shouldn't happen that way. It just shouldn't go the way it's going. It shouldn't go this way. I'm called to, like, hey, even in end-of-life care, I'm called to provide care in a way that, man, I really don't. And that can cause a real moral injury to a person. And it's something they can carry for a really long time, just like trauma-informed, just like a trauma injury. And what happens to people, though, is that one compounds the other. And oftentimes we'll see in frontline workers, first responders, corrections officers, nurses, doctors, that they have compounded trauma because they have trauma and moral injury. And when you compound the two, it becomes really a complex type of injury, and it really requires really comprehensive care across this whole spectrum of care that we would offer.
Now, if a person has experienced trauma and moral injury in those kinds of ways, how do they ask for help? How does it come out, do you think?
So I've seen it come out in so many different ways. I mean, and we see it happen for folks who are struggling with addiction. That's one way that we see people. It comes out that way.
Because they're self-medicating.
Self-medicating. Comes out in mental health, just mental breaks. It comes out in the way that their coping skills, they're just coping, and there are culturally acceptable coping skills. You know, probably some of the traumas that I receive, I cope in culturally acceptable ways. Like I'll binge watch Netflix at night. Do you know what I mean? Like, and it's culturally acceptable for me to eat too much ice cream and a little too much ice cream and watch a little too much Netflix. And so I think everyone copes in different ways. And our job as chaplains and people who care for people is to just meet them where they're at with presence and understanding, and let them know that they're seen, that they're heard, and that we care. And I think oftentimes what I've found that if a person can feel like they've been seen, they can feel like they've been heard, and they can feel like you've been present, oftentimes that does so much to help a person. Yeah.
So what are some of the things, like currently you're trying to recruit additional chaplains to work within the hospital. What kind of training do you put a volunteer through?
Yeah, so the runway is you come to an informational seminar. I even actually got the dates written down here, July 8th and July 22nd and August 22nd, August 26th at 10 o'clock at Binghamton General Hospital. We're going to be having recruitment events. And it's usually the best place to start is to come in to one of those events, and we kind of explain the whole scope of chaplain care, the type of care we provide. And then they go through an onboarding process. So they do an application with the Council of Churches, and then they do an application with the hospital. It requires a robust background check, and they go through that background check. And then they do an interview with us. Either myself or UHS has a spiritual care staff member, her name's Rachel, or so they'll interview with me or Rachel and make sure that they line up and understand what chaplaincy is. Because some people have a misconception. They think they're going to go in there and lay hands on people, or the job is to convert people to a particular religion, and that's not the job at all. And we have to make sure they can get their mind around what the task at hand is. And then once they have gotten through the interview, then we provide some additional training. They usually round with one of our staff chaplains. I have a couple in training right now, and they round with me numerous times until they feel like, you know what, I'm ready for you to just follow me. So they watch me, and they go with me, and I introduce them, and they go through numerous hours and hours of that. And then when they feel ready, I watch them, and we kind of critique. We teach them a process to kind of assess a patient. What's the reason that they're there? What is the need assessment? What's the need that the patient has? And then how do you care for a patient presenting these type of needs? So we provide all of that training for our chaplains. And then there's additional opportunities. We have tuition reimbursement. We're getting ready to do a clinical pastoral cohort, so they can get some clinical pastoral training if they're interested. We'll be doing that in the fall.
And how would a person go through if they were thinking about becoming involved in clinical pastoral education, which is CPE?
Yeah.
How would they go about doing that?
So simply get on the team, because that's the best place to start. Get some exposure and experience. Make sure this is the thing that you really want to do, because CPE, you've gone through it yourself as well as I have. It's very robust. We're talking 100 instructional hours, classroom hours, 300 clinical hours, and that's just for one unit. To be fully endorsed, there's 4 units. Usually we like to see anyone who's going to become a staff chaplain have a minimum of 1 unit. And so you got to really know this is what you're going to want to do if you're going to invest this type of time into it. So that's why we encourage, get on the team, become a volunteer, start getting engaged in the work, and then say, hey, is this something that I really want to do? And then we provide some tuition reimbursement. They have skin in the game as well, but I think we meet them about halfway now.
It is half.
Yeah. And so, so it's really great. That's kind of how I got involved. I think that process works best. You get exposure. Make sure that really this is the thing you're wanting to do. This is what you're being called into.
So take baby steps then.
Yeah. How do you eat an elephant? 1 bite at a time.
Right.
Yeah.
Exactly.
Yeah.
Let's hope that it doesn't take a whole elephant to get involved in it before you figure out whether you want to do it or not.
No,
right?
for sure.
So really, I mean, we're dealing with a lot of patient interactions. You have like 18,000.
Well, 10,000, almost
12
12,000 patient interactions, and probably 6,000 staff interactions.
Now, what are the differences between the needs between the staff and the patient?
Well, the difference really is with a staff member. I've been at BGH coming up on 3 years. And I know the staff well. I'm at BGH 4 of my 5 days. And so I have developed relationships. And with relationship, as you know, that gives permission.
Right.
And so with staff, you establish a different level. And it's almost like a pastoral level of relationship. You're given permission in a way to speak into their lives. And they're coming to you with the things that we all face, relationship issues, family things, their own life issues. And so they come to you with those things, and you have an opportunity to meet with them and actually go deeper, and then even continue to check in on them, provide care. It's a long-term relationship. It does feel more pastoral to me.
And it also, well, it's interesting to me that, first responders and people that are like in the medical profession itself, I mean, they're dealing with situations that, that they're compounded by their home situations. So they're involved in these end of life or very difficult situations medically for patients. They all have feelings. They all have care. They care for people. They get involved in this work because of usually because of that, the fact that they care.
Yeah.
So how?
And then on top.
Yeah.
Yeah. And then what we see too is then oftentimes when people are sick, you're meeting them at their worst moment.
Right. Exactly.
And often the way they act. The way I act in my worst moments, I don't think I want to be judged by my worst moments.
Let's hope not.
Yeah, and so, but they're in their worst moments as well, and sometimes they react and act in ways that are just not appropriate.
Right.
And usually the people who receive that first, we see that the nurses do.
Well, yeah.
You know what I mean? Instances where it's just really out of bounds, and they have to, this is the craziness, the heart of nurses that I've come to really appreciate is they'll get abused in a way and come back and still have empathy and provide care to the person. And just it takes a real special person to do that type of work. And that's why it's enjoyable to also provide the spiritual care to staff.
It requires a bit of decompression, right? Or some kind of reflection in order for them to come to the point where they can offer that kind of presence, right?
Right. And what's amazing, I've had the pleasure to be at UHS, and these nurses there are just award-winning nurses. They're just quality care, quality nurses. I tell people, if I was sick, this is exactly where I'd want to be, based on my experience.
And really, for a chaplain to be involved in those situations too is pretty it's important too, because you're also dealing with your own life, your own situations, and you have to deal with these other very complex emotional situations as well.
Yeah.
And you have to be able to be the presence in the midst of that offering the gift of presence, showing up and not really knowing what the outcome of that interaction is going to be like, right?
Right. Yeah.
So, like, what do you do for yourself in the middle of all of that?
So CPE does teach you some grounding techniques to kind of center yourself. I like to wash with, because in and out, we're cleansing our hands. And if it's a bad one, like one that was like, hey, this was tough. Instead of just foaming in and foaming out, I'll have a tendency to wash my hands, like with real water after that one. Just take enough time to like just really enjoy warm water over my hands, give myself a second to regroup. And the nice thing is too, what we tell our volunteers, we tell all of our chaplains is, if you need to, go to the chapel, go back to the office, take a breath, take a breather, get a cup of coffee, relax for a second. You know what I mean? We understand you're carrying a lot, and so you need to take the time and do the self-care. And so we encourage that. I have my own self-care routines that I do. I make sure I spend a lot of time recreating when I'm not at work, you know?
Mm-hmm.
Yeah.
So it's important to be a well-rounded person in order to be involved in this kind of ministry.
Oh yeah, I mean, and what I've learned in ministry, it can't be your end-all be-all anyways.
Well, yeah, that's true.
And so many people attach their identity to their purpose, and that's not what God designed us to do. And when we do that, we actually end up misplacing our identity. And so it is part of my gifting. It's the thing I do, but it's not my whole identity.
And our identity is really shaped in Christ, right?
Yes.
So,
yeah.
like, how do you communicate that to them?
Well, and so it depends on the faith tradition we're meeting with too.
Well, yeah.
Yeah, and so some faith traditions, it's not communicated at all.
Right.
But it's amazing though how many times I'm actually using the teachings that we find in the Bible, but just presenting it in a manner that's palatable, you know?
Yeah, because we are created in the image of God.
Right,
I mean,
everyone.
Even a Christian can acknowledge that part of it, right?
Yeah.
So it's
yeah.
So if we're all created in the image of God, we all have an endued worth because of that comes from God Himself, or
right.
from God's self. That would give us then a sense of identity that would be capable of going into any different situation and being comfortable in it,
right.
in some ways, right?
Yeah. And the idea, that's why we do the work too, is that everyone, regardless of their religious credo, has an innate value and is made in the image of God.
Right.
And so they matter. Each and every interaction, each and every person is a soul. Each and every person matters.
Yeah.
And their story matters.
My guest today is John Snider, and we've been talking a lot about the hospital ministry. It's our oldest ministry at the Council of Churches, and yet, you know, in a lot of ways, it's also becoming very new, especially as especially as the issues of spiritual care become more widespread within the hospital, and people understand how important it is.
Yeah.
So how do you fit into the entire work of you at UHS?
Well, we are part of the entire healthcare team.
Right.
Medicine has now recognized that outcomes for patients are greatly improved when spiritual care is involved.
Right.
And so we're integrated into the team. I probably talk to the hospitalist, the main doctor at the hospital. I have multiple conversations a day with him. Some just, hey, we're friendly conversations, but we have patient interaction and conversations about patients that are in the hospital. He has a handle on every patient in the hospital, and we talk about patients. I'm directly involved in patient care. It's not uncommon for him or a nurse to stop by and, hey, could you go see this patient needs extra, or we're dealing with an ethical issue, ethical dilemma or issue around a patient care, and we're pulled into those, or hey, this was really a lot of trauma for our staff. Could you come in and help debrief, help care for the staff in this time of need? So those are a lot of the ways that we integrate into the care team at UHS, for sure.
So are you involved in the ethics team as well?
I have been pulled in. Now since we switched up a little how the roles are divided, since we have Rachel as the spiritual care coordinator at the hospital, she does most of the ethics stuff. I have been pulled in on ethics and trauma, and on occasion I still am. Very recently I was in on one for a length. It was a long-term thing.
What kind of ethical issues come up at the hospital?
Oftentimes end of life, long-term care, no family, finding placement, type of care needed. When you're talking with a person with chronic, long-term illness that really is just persistent, you know. They're just not in a state that anyone would want to be left in.
Right.
And no family to speak up or to interact.
Right.
And at that time, the hospital has a duty to step up.
They do.
And they do. And they do an amazing job there. They really go. My experience has been they go above and beyond for their patients there. That's been my experience.
So John, what are those dates again, and how would people be able to get in touch with you?
So July 8th at 10 a.m. at Binghamton General Hospital, July 22nd at 10 a.m. at Binghamton General, and then August 26th. You can call my office at 607-762-2446. I had to write it down here because I never remember that. But actually, if you call, is probably the best way. You can also email me at jsnider, S-N-I-D-E-R, at broomecouncil.net.
And then they could express their interest, find out a little bit more about hospital chaplaincy and what it would mean to be a volunteer at the hospital, and then how they might be able to figure out whether this is something that they would really like to do or not.
Yeah, and that's why that informational session is a good place to start, because you can hear, I talk for about 30 minutes, we answer a lot of questions, and that way you can determine, really, should I take the next step?
Right.
You know, because some people go to that informational session and realize, you know, this is not the type of ministry I thought it was going to be. And so that's fine, but we have the type of ministry we do, so.
Well, John, it's been great having you back on Encounter, celebrating our 85th anniversary of hospital ministry. And for all of you who are watching, viewing, listening today, pray that you would have a great Sunday, and that you would be filled with God's grace, God's love, and be able to be a gift of presence to someone else who's having a hard time in their journey. Have a great day.